Afraid of giving birth. Birth fear, birth plans, and what actually helps. A parenting guide from Creative Minds Montessori. Being scared of labor is normal, not a character flaw. Clinically significant fear of childbirth touches roughly 1 in 7 pregnant women worldwide, and unlike most pregnancy worries, it responds to treatment. 3 levers have real evidence behind them: a proper childbirth class, 1 page of flexible birth preferences instead of a rigid script, and continuous labor support from one calm person who never leaves the room. If the fear is running your life, that's tocophobia, it's treatable, and telling your midwife early is the highest yield thing you can do. This is not medical advice. Talk to your OB or midwife. Afraid of birth is almost never one fear. When researchers sorted out what women dreading labor were actually afraid of, distinct strands came out: pain they couldn't endure, physical damage, the baby's health, the hospital itself, not being heard, being left alone, and for first-timers, plain fear of the unknown with no map at all. Naming which strand is yours matters, because they have different answers. Fear of the unknown responds to information. Fear of not being heard responds to a written plan and an advocate. Fear of the pain responds to knowing what's actually available on the day. The strand that gets underrated is control. Women in these studies describe fearing they'll lose themselves more than they fear the pain. One image comes up again and again: being caught in your own body, where there's no turning back. And it isn't only a feeling. A strong sense of losing control during labor is linked to sharper awareness of pain, and to a birth being remembered as traumatic. 2 of the most reliable ingredients of a bad birth experience are not being given enough information, and being cut out of the decisions. Some fear is near universal, but clinically significant fear of childbirth affects roughly 14% of pregnant women worldwide, and about 10% in high-income countries. That's a couple of women in every childbirth class. And here's why taking it seriously is more than kindness: fear changes the birth. High childbirth fear is the main driver of maternal request cesareans, and it tracks with more epidurals, more inductions, more births remembered as negative, and roughly 38% higher perinatal costs. The fear is not a passive passenger. It gets a hand on the wheel. Where does the fear come from? Mostly from other people's worst days, brutally honest stories from mothers and friends, birth on television, which is essentially always an emergency, a previous traumatic birth, prior loss, and background anxiety. Notice what's missing from that list. Your own labor. You've only met the trailer, cut for maximum drama. So it helps to know the lived version. In a survey of about 900 American mothers, 46% of first-timers said labor pain was better than they expected, and 90% said their pain management worked, whichever method they chose. Fear of childbirth is as old as childbirth. What changes is what people do with it. From 1907, German physicians combined morphine and scopolamine into what they called twilight sleep. It didn't remove the pain, it removed the memory of it: darkened rooms, gauze over the eyes, leather straps, then waking with a baby and no recollection. And here's the irony worth sitting with. Twilight sleep was campaigned for as an American feminist cause, a woman's right to a painless birth. 60 years later, the natural childbirth movement used exactly the same banner for the opposite thing. Control flipped a full 180 degrees. The partner's seat has moved just as far. Into the 1960s, fathers were parked in waiting rooms. The natural childbirth and women's movements pushed them into labor rooms in the 60s and delivery rooms through the 70s and 80s, over real resistance. Couples threatened hospital boycotts, and one father was photographed handcuffed to the delivery table so he couldn't be removed before the birth. Today roughly 90% attend. Meanwhile, epidurals became practical from the 1970s, and around 70 to 75% of U.S. births now use epidural or spinal pain relief. Choosing your pain relief is new. So why does it feel harder now? Partly because the horror story pipeline has been industrialized: strangers' worst days delivered to a pregnant woman at 2 a.m., and other people's stories in media are exactly what the research names as primary fear sources. Partly because birth became an identity battleground online, so expecting parents inherit judgment stacked on top of the fear. The same technology cuts the other way, though. Real evidence-based information is one tab away. Hospitals put their classes on video, and referral pathways for severe fear genuinely exist. Your great-grandmother's fear was the same. What she feared was not. The first common move is avoidance. Skip the class, change the subject, mute the topic. Short-term relief is real, and some curation is genuinely protective. Not every input deserves your attention at 36 weeks. But for first-timers, fear of the unknown is one of the main engines of the whole thing, and avoidance keeps the unknown unknown. Class attendance shows a dose response. Women who attended childbirth preparation classes regularly reported significantly less fear, anxiety, and depression than irregular or non-attenders. Worse, avoidance blocks the single highest yield step available to you, which is telling your midwife early that you're frightened. The second move is the fortress birth plan. Control the fear by scripting every detail. Writing down preferences is genuinely useful. It forces you to learn your options, it opens a real conversation with your care team, and it helps you walk in feeling prepared. As one nurse midwife puts it, a birth plan is not a test you can fail. But birth is the least scriptable day of your life. About 1 in 3 U.S. births ends in cesarean, 32.4% in 2023, and most induction and epidural timing isn't decided in advance. When a rigid script meets that, the gap fills with grief and a private verdict of failure. The third move is an escape hatch at either pole. Ask for a cesarean purely to skip labor, or commit to an unmedicated birth as a test of your worth. Both are legitimate choices when made freely and with information. But a choice made from panic is not the same as a choice made with support. Fear-driven preference frequently reverses once the fear is treated. Midwife-led counseling averted roughly 1 cesarean for every 5 women counseled. And the opposite pole sets its own trap, because if an epidural becomes necessary, it arrives preloaded with the word failed. Treat the fear first, then choose. Hold this as a tendency, not a rule, and it's about position, not gender. The asymmetry here is structural. One body is on the line, and the other person is a witness. The pregnant partner's fear tends to organize around pain, loss of control, injury, and the baby. The other partner's organizes around helplessness, being present, feeling responsible, and having nothing useful to do with their hands. In a German study of 318 fathers surveyed days after the birth, 94% were glad they'd been there, and 36.5% reported fear, 23% helplessness. The clash pattern follows from the positions. The pregnant partner usually needs the fear witnessed, talked through, not solved. The other partner, whose own helplessness is unbearable, responds by problem-solving or minimizing, which lands as dismissal. What fixes it is specificity. Fathers who were given concrete tasks and clear information felt they could actually support their partner. So write the partner into the birth preferences, who applies counter-pressure, who holds the water, who asks can you walk us through the options, who stays with the baby if you're separated. For single parents, that seat is empty by default, and that's exactly where a doula earns her keep. The principle underneath all 3 methods. You cannot control how your birth goes, and trying harder to control it makes the fear worse. What you can control is how much you know, how you'll be treated, and who is in the room with you. Every method that follows trades outcome control for agency, which is the thing the fear is actually asking for. The first method, take a real childbirth class and swap the imagined labor for the actual one. Fear of the unknown runs on a blank map, and your brain will not leave a map blank. It fills it with the worst thing it has ever seen. Education replaces that improvisation with a sequence of understandable events, and builds self-efficacy, the sense that you'll know what's happening and what you can do. Randomized trials and a meta-analysis find antenatal education reduces fear of childbirth, anxiety and depression, raises self-efficacy, and lowers reported labor pain intensity. Practically, book a structured class in the second trimester, when you're past the early exhaustion and not yet too uncomfortable to sit through it. Choose one that teaches rather than one that campaigns, and go with your partner or support person. Ask the specific frightening questions out loud, because that's where the real corrections live. In that same survey, 74% of mothers wrongly believed there's an early cutoff for an epidural. In the third trimester, tour the actual labor ward. Expect the fear to drop over weeks, not in one evening. The saboteur is a class with an agenda. The second method, write birth preferences, not a birth script. The goal is agency, not control of outcomes, and the distinction is the whole method. You cannot predecide whether you'll need an induction, but you can absolutely predecide who is in the room, what comfort measures you want available, and how decisions get communicated to you. That aims straight at the loss of control fear. And naming Plan B before the day means a change of course reads as we move to Plan B, not I failed Plan A. 1 page, maximum. If it doesn't fit on a page, it's a script again. Use flexible language throughout. My preference is, I hope to. Cover 3 phases. Labor, movement, water, lighting, who's present, when you want to be asked about pain relief. Delivery, skin to skin, who cuts the cord, who stays with the baby. And the version you hope not to need, if a cesarean becomes necessary, partner present, drape lowered if you'd like to see, skin to skin in the operating room when it's safe. Review it with your midwife around 32 to 36 weeks, not by handing it over in triage. The third method, line up continuous labor support. Fear shrinks in the presence of someone calm who has seen this before. A supporter supplies reassurance, coping guidance, comfort measures, and advocacy, which map almost exactly onto the Fears Women report. A Cochrane review pooling 26 randomized trials across 17 countries and more than 15,000 women found continuous support associated with about 25% fewer cesareans, labors around 40 minutes shorter, and 31% fewer births rated negatively, with no identified harms. Honesty about the evidence, it was graded low certainty, so treat those numbers as a direction, not a guarantee. Interview 2 or 3 doulas in the second or early third trimester, and wait fit over resume. You want the person whose presence lowers your heart rate. If cost is the obstacle, ask about sliding scales, community doula programs, and hospital-based doula services, which are more common than most parents realize. Then brief them on your specific fears and hand them the preferences page, and define the division of labor so your partner ends up more involved, not displaced. The mistake that undoes this one is hiring someone and never briefing them. An unbriefed supporter defaults to generic encouragement, which is not advocacy. This may look like the least related item in a birth fear article, and it's one of the most useful, because fear feeds on open loops. You don't get to know the birth, or the baby's temperament, or how your body will recover. But what happens when leave ends is one loop you can close before the birth, and it has a deadline, because infant care waitlists punish waiting. Guidance is blunter than most first-time parents expect. Start the search in the first trimester. Touring an infant room while visibly pregnant is normal, expected, and quietly therapeutic. What to look for at any center, ours or anyone's. Safe sleep, babies on their backs in bare cribs, no loose bedding or bumpers, and a clear answer about how naps are supervised. Ratios, 1 caregiver to 4 infants is the recommendation, so ask what's actually maintained during staff breaks and the pickup crush, not just the licensed minimum. Feeding and daily logs, will they follow your feeding plan, and will you get a daily report of feeds, diapers, naps and mood? And gradual start, can you visit first and ramp up slowly? That tells you how they handle transitions generally. This is not medical advice, talk to your OB or midwife. Some fear is near universal. Tocophobia is different, an extreme, life-shaping fear classified as a specific phobia. Worth a conversation, not a crisis, avoiding a pregnancy you actually want, concealing the pregnancy, feeling detached from the baby, nightmares or panic that trace back to birth dread, or fear rooted in past trauma. It responds to treatment better than almost anything else on the pregnancy worry list. Tell your midwife early, they will not be surprised or judgmental. Postpartum Support International is 1-800-944-4773. In crisis, call or text 988. There is no correct way to give birth. Unmedicated with a doula, an epidural at the first serious contraction, or a planned cesarean chosen calmly after the fear was treated. 90% of mothers rated their pain management effective whatever method they used, which is quietly radical. The method matters far less than being informed, supported, and heard. Every generation was certain it had found the right birth, and every generation's answer was different. So hold two things: you can prepare thoroughly and still not control the day, and grief for the birth you didn't get can live alongside love for the baby you did. For the full guide and more parenting resources, visit creativemindsmontessori.com/parenting.